Thank you so much. So we're going to get started here. If you were in my EBCLS lecture, I used every minute they gave me to teach. This one's going to be quick. There's not much to EMS sedation, honestly, in terms of evidence and practice. But we'll have some time to discuss some different protocols and what you guys do. So let's get started. First off, this link will take you to my handout, my slides, and my references. Everything you need to know is on that handout, and also all my contact information. That link will be on my last slide as well. But again, all my slides, references, and handout can be found at that link. Also, JaxEMS.com. It's a website we set up a couple years ago. It's a mobile-friendly website. We use it for feedback, both feedback coming to us and feedback to the providers. Also have lots of lectures on there. This lecture and my EBCLS lecture will be on there as well, recorded. So please check it out. All right, so I have no financial bias. I do have a lot of practice bias. I have been dubbed the king of ketamine in my hospital. I'm very proud of that position. It doesn't come easily. Let's see. But yes, I do have a lot of practice bias because I believe in some of these medications wholeheartedly. But I'll talk to you about why that is, and we'll get down to that. All right, so why do we sedate people in the field? To control them, why?
Safety.
Safety? Perfect. Whose safety?
Ours. Well,
Perfect. Ours and theirs, so to control them. So what are some reasons why we need to control them? Are they just an asshole, or? Seizure, perfect. 99% of the time they're just an asshole. 1% of the time they seize. What else? Psych? Excited delirium, anything else? TBIs? There's one other thing I want to talk about. Not just psych, asshole. What's up? Anxiety. Perfect. Anxiolysis. So perfect. All right. So first off, psych. Very good reason. I work in a very busy emergency department, and we sedate a lot of psychiatric patients. A lot of this is for your safety. A lot of this is for the patient's safety, and just to facilitate transport. Excited delirium. Someone brought that up. So we'll talk about that as its own entity. So what is excited delirium? We say it all the time. What is it? Anyone? What causes it? It can be drugs. What else? Okay, like a traumatic experience. What else? Withdrawals, maybe? So you guys could keep answering 1,000 things because we don't know. It's caused by drugs, it's caused by psych, it's caused by a lot of things. The other thing is, it's not a well-defined entity. What are some signs and symptoms of excited delirium? You all have seen it, but how would you describe it? What's that?
Extreme agitation.
Extreme agitation, perfect. What else? Hyperthermia. What else?
Very strong.
Perfect. So things we think about: extreme agitation, superhuman strength, impervious to pain, hyperthermia. So what kills excited delirium patients? There's a couple things, but there's two main things. What's that? So something like rhabdo, which is when you build up a lot of enzymes from broken down muscle. What else? Acidosis. Most commonly it's going to actually be hyperthermia, but all this goes together. Then working out what else kills excited delirium patients. This is a very contentious issue because the other thing that kills excited delirium patients. We do, and police officers. That's assault, brother. Yeah, this is a very contentious issue, and there's actually a field of thought that excited delirium was a term that was developed by police officers and emergency physicians to cover our asses. So when someone dies in the field, we say, oh, they died of excited delirium. Not they died because I was sitting on their chest for 10 minutes. So it's actually a very contentious issue, and it's not a totally accepted medical issue. It's accepted by American College of Surgeons, and pre-hospital folks accept it as well. But just know that it is actually a legal term, and it causes some issue. Because we've all seen cases of this patient who were trying to do the right thing, cops are trying to do the right thing, but the patient dies. And sometimes it's because they become hyperthermic, acidosis, rhabdo. And sometimes it's because we sat on their chest trying to restrain them. So we just need to be careful with that stuff. All right, the last reason, procedural. That's another reason pre-hospital. What are some procedures we might need to sedate a patient for? Cardioversion. What else? What's that? Intubation, delayed or rapid sequence intubation. Cardioversion, pacing. Someone else earlier said anxiolysis. Transportation is a procedure, especially if you're in flight or even an hour-long transport, you have a little kid or something like that. That's a procedure, and you may have to give them a little anxiolysis for that. Another procedure we'll bring up later is traumatic entrapments. So someone might have, you might do a field amputation, or you might have someone whose leg is caught, or they're entrapped, or you're having to actually kind of reset a dislocated or a fractured limb, and that's a great reason for anxiolysis and sedation. All right, so when I come up to this patient and I'm trying to choose my medication, there's a couple things that go through my head that I want to know about the medication. So I'm going to choose medication A, B, or C. What do I want to know about each of those meds that's going to help guide my decision?
How long?
How fast? How long? What else?
Contraindications.
Contraindications. What else?
Half-life.
Half-life. So it's about how long it lasts. What else?
Anticipated side effects.
Side effects. Beautiful. One more.
How can we administer?
Perfect. All right, so first off, onset, slow or fast? Is this going to hit them, boom, 10 seconds they're down? Or am I going to sit there for 30 minutes waiting for this to kick in? Secondly, duration. Is it going to come off fast, so 10 minutes later they're back to normal, or is it going to be 2 hours? I want to know that. Especially in my emergency department, I'm trying to move these patients. I don't want someone sedated for 4 hours and I can't get them out of my emergency department. Route, how can I give it? IV, IM, intranasal. Those are going to be our most common routes that we're going to give these medications. But don't forget about IO. I look at a lot of pre-hospital protocols, and very few of them really usually include IO when they're talking about actual sedation. The IO is usually reserved more for cardiac meds or cardiac arrest meds, but I think it's a great route for sedation. We had an excited delirium patient a couple weeks ago, and he was just manhandling our staff. We had 6 security guards on top of him. I was up top. I dropped an EJ in his neck, and he was able to get it out pretty much with the shoulder and just rip it out. And our nurses have needles around trying to do stuff. I said, guys, back up. We couldn't get a good... Actually, I tried IM medication on him. I'd already given probably 8 of Versed IM. Midazolam, wasn't touching him. I said, fuck it, I'm dropping an IO in him. Went down. Remember, excited delirium, impervious to pain. And again, in that situation, I don't care. It's his safety, my staff's safety. IO, ketamine, 200, down 30 seconds. So don't forget that. The IO, you can put any medicine through an IO that you can put through an IV. And it's much easier, again, with IM medications. We'll talk about this ketamine. You have to have the right concentration. You shouldn't be dropping 20 cc's of meds in someone's thigh, which I've done before, but we shouldn't. But you can easily infuse that into an IO. So side effects as well. Is my patient going to stop breathing? Are they going to go into cardiac arrest? Is it going to drop their blood pressure? Is it going to make them act crazy? So things we have to think about every medication we put in someone. All right, so this patient right here, if I had that patient, he came to me, and I was scared shitless that this guy's going to rip my face off. I need to think of a medication that I want, and my ideal medication would be Perfectional. I have trademarked Perfectional. You cannot steal it from me. But this would be that ideal medication. So the onset of this medication is right now. The second I give it, it works. It lasts exactly how long I want it, has no side effects, and I can give it anyway. I can give it rectally if I want. I can give it any way I could possibly think. Unfortunately, we don't have that medication. So we're going to talk about some very common pre-hospital and ED medications. And in the end, I want you guys to kind of speak up if there's anything else that you guys use. So we're going to talk about Haloperidol, also known as Haldol. We'll talk about Midazolam, also known as Versed. Lorazepam, also known as Ativan. We'll talk about Etomidate, and we'll also talk about ketamine. So first off, Midazolam. Who has this in the protocols? Perfect. Beautiful, beautiful drug. I love Midazolam. For use especially in chemical restraint. So the dosing is about 5 to 10 milligrams IM. It's also about 2 to 5 milligrams IV. You can pretty much go up from there and still have not too much of a sedating effect. It's pretty good safety margins. It's pretty fast. Usually when we give it, within a minute, 2 minutes of IV, we're seeing a good effect, maybe a little bit longer with IM. But really, within 5 to 10 minutes IM, the patient still is really starting to chill out for us. It's pretty quick off. So you'll see in a little bit, there's article I talk about as to why I actually like that it comes off pretty quick. Like I said, sometimes we sedate someone and they're down for hours and I can't figure out what to do with them. I can't talk to them to see if they're acting right or not. So I like the quick on, quick off is nice. For me, this medication is to control that situation up front so that other things can be done. Route-wise, it can really be given almost any route. There was a nice study called the Rampart trial that was a pre-hospital study, about 900 patients. It was status epilepticus, but what it told us was that IM Versed, or Midazolam, was as effective and actually a little bit better than IV Lorazepam for controlling these seizure patients. So that was a nice, good quality pre-hospital study that showed in a lot of protocols after the agency started going to Midazolam. And it's really cool because, again, you can give it IM and it's as effective as getting that IV and getting your Lorazepam, and it acts a little quicker as well.
What is it called? Rampart?
Rampart. Yep. And again, I'll have a link at the end that has my handout in it, and the name of it is on there as well. And the reference list is on there as well. Side effects, hypotension, respiratory depression, just like we think with any benzodiazepines. I forgot to mention this, but this is a benzodiazepine, so it works on GABA receptors. You never need to know the details of physiology, but mechanisms, but it's nice to know kind of what classification each medication is. Literature-wise, like I said, talk about the Rampart study. There's also a study in 2003, a randomized controlled trial. I love this study when I teach my residents, and this changed my practice when I learned about this study. What they did, it was a randomized controlled trial. So highest level of evidence is really our randomized controlled trials because you're taking different populations of patients, you're blinding people to what type of meds they're getting, and you kind of take out the placebo effect with that. So what they did either Versed, 5 milligrams IM, 5 milligrams Haldol IM, or 2 milligrams Ativan IM. And they did that randomly and gave them to patients that needed chemical sedation. And what they found, Versed was quickest on, quickest off, and there were no changes in adverse side effects from any of the medications. Haldol was kind of in the middle. Lorazepam took the longest to go on, but essentially what it showed was they were all equal in terms of bad outcomes or side effects, and there actually really weren't any bad outcomes at all. But again, that changed my practice. I'll show a slide in a little bit how people come to our hospital, in the emergency department, and they're crazy, and the residents yell out, 5 and 2. What's 5 and 2 mean? Anyone know?
5 milligrams.
So what it means is 5 milligrams Haldol, 2 milligrams Ativan. That's what 5 and 2 means to us. It means a lot of things to a lot of people. B52 is a thing people use sometimes. But when I trained, that's what it was. There's always everyone got 5 of Haldol and 2 of Ativan across the board. Because people wouldn't think about it. They're just like, oh, here's what we're giving them. And 6 hours later, you're like, come on, dude, wake up. Like, I need to get you out of my department. So this changed my practice when I learned this, knowing that Versed was as effective as Haldol and less side effects, quick on, quick off. Because what that means is I can give that boom up front, control the situation, restrain them if I have to, allow that patient to wake up a bit, and at that point decide, do I need to continue sedation? Do I need to do antipsychotics? Do I need to do something else? But it works as a nice upfront controlling agent. Lorazepam. Anyone carrying Lorazepam? Okay, it's really fallen out of favor. I put it in the talk here, and then suddenly I was like, is anyone still carrying it? It really has gone out of favor just in the last 5 or 10 years. Very effective medication, especially for seizures. It's a great medication, like I said, but that Rampart trial, I think kind of changed things, and I guess that's why you asked about Rampart trial. It kind of changed things, just showing how Versed was nice and quick. But Lorazepam, another benzodiazepine. It's a GABA receptor. 2 to 5 milligrams IM, 1 to 2 milligrams IV. It's slower onset than the Versed. That's the problem. You give it to a seizure patient or even an actively psychotic patient, you're waiting really a couple minutes, maybe 10, 15 minutes for it to kick in if you do it IM. It's a longer duration as well, so sometimes this is great. If someone's having refractory seizures, it's nice to get a couple hours on. If I have a psychotic patient, we've controlled the situation, we know what's going on, it's going to be a while till they get a bed or something, and then I'm hitting with Ativan because I know I'll have a couple hours of sedation. Route-wise, you can really give it any route. IV and IM are going to be the most popular routes. Our side effects are the same as any benzo. It's respiratory depression, hypotension. That's really it about Ativan. So haloperidol or Haldol. Who's carrying Haldol? Okay, so Haldol is an antipsychotic, so it acts on dopaminergic receptors. We don't really totally know how it works, but that's the classification it's in. In general, the dose is 2 to 5 milligrams IM or IV. Who has a protocol for IV Haldol? Okay, so this is a little contentious issue. The reason I put the star there, IV Haldol actually isn't FDA cleared for, or Haldol isn't FDA cleared for IV administration. And I get this every time. Certain concentrations of it, but I ask my nurse to give it, and on the bottle it says not for use in IV administration. Why is that? Anyone know? So the problem was, and we'll talk about this a bit, it prolonged QTC. So if you know anything about medicine, you know that every medicine we actually give people prolongs their QTC. But Haldol had a couple of cases where they got really worried about it, and there's actually a black box warning for giving it to patients. It was really shitty evidence. It was a really inappropriate black box warning, honestly. We do need to be careful with it if we know someone has a long QTC or a history of prolonged QTC. So in the ED, generally, if we're going to give it IV, we'll want to have an EKG on the patient. But that's why if you ever hear anything about it, about giving IV, it really is best to use IM. Another fun little pearl that just popped in my head, what's another great use for Haldol that's not sedating someone? Anyone know? The emergency department has become my favorite drug for this problem. What's that? Oh, it's awesome. It is the best headache medicine you can possibly give. Anyone ever used Haloperidol? Did you guys ever have that? That was the best headache medicine ever created. And of course, it's no longer available. Haldol is in the same family as that. So if you ever come to me and I treat you with Haldol for headaches, not because I think you're crazy, it's because it really is a rock star headache medicine. Onset-wise, it's kind of a turtle bunny. It's kind of in the middle. It's quick, but it's not as quick as Versed and not as slow as Lorazepam. It lasts longer than Versed, so you'll have a couple hours of sedation with this. Route-wise, you can really give it anyway. Most popular is going to be IV or IM. Like I said, you do have that FDA warning with the IV use. It can be used intranasally. There's not much evidence on it. And the main concern is being that QTC prolongation. So the main side effect of it, there's really not much side effect. If you do it with other medications, it can increase respiratory depression, but the main thing is an acute dystonic reaction. And essentially that just has to do with dopamine receptors. You can see it with lots of antipsychotics and some other medicines. And essentially the patient just gets kind of this torticollis and their muscles spaz up, and sometimes they get the arms going like that. And I've seen plenty of stroke alerts that end up just being this, because they're kind of like this and they can't smile and they have facial droop. So it's really interesting. How do you treat this? Benadryl. It's a weird thing. You see this come in, stroke alert, oh my God, the person's dying. Benadryl, they're better. So it's really weird. Until you see it, it's really weird. Yeah.
We actually give it with Versed as a cocktail.
Mm-hmm. Oh, the Benadryl or
yeah,
which?
It's Benadryl and Haldol. Mm-hmm. Can they be mixed together?
Oh wait, so you give Benadryl with the Haldol, you're saying?
Yeah, it's a cocktail.
To avoid this, or why?
To avoid that.
Okay, so the question was, they give Benadryl with Haldol to avoid acute dystonic reaction. Can they be mixed? I don't know. You can look that up in some pharmacy book. I'm not sure. But I'm not a huge fan of that practice, and no great reason. Compazine is a medicine we use for headaches a lot, and we always give Benadryl with it because of the acute dystonic reaction. The odd thing is acute dystonic reaction only happens about 5%. It's actually more akathisia. It's this weird feeling you get when you get Compazine, but it only happens about 5% of patients. So we're giving Benadryl in every patient for 5% of the population. It just doesn't make sense, but most of us give it because it puts the patient to sleep, and 2 hours later they wake up and they feel great. So that's the main reason they give it. I always get weird with mixing meds when it comes to sedating patients.
I just don't like the idea of 2 exposed needles.
Yeah, and I don't need it, and that's why I'd say I would just do Haldol. Just do Haldol, honestly, or just do Versed.
Protocol too.
Yeah, I tend to be a single agent person if I can, for the reason that, and we'll talk about this in the ketamine literature, the patients who end up getting intubated are usually the ones who are getting multiple different medications. And then medication errors, big thing, and also you're having multiple needles out in the field. So that's just my personal opinion. If it's not needed, it's not needed. It probably does help sedation. There's the B52 protocol people use a lot, which had Benadryl and also Haldol and some other stuff. So everyone has their own little thing. At the end, I kind of want to get you guys' input as to what you use. The acute dystonic reaction is not life-threatening at all, but benzos can treat it, and also Benadryl can treat it. Etomidate, anybody using this for sedation outside of intubation? For what?
Pacing.
Okay, perfect. Yeah, and this is interesting. We rarely use it for procedures, but in residency, I remember someone had me use it once for, I think it was pacing or reduction. Well, yeah, and it really, I actually like it now. It's kind of a go-to for me when I need a quick sedation for a procedure, and I'll talk about that in a bit. I put 10 milligrams IV because that's the dose I use for adults for sedation. Again, not for intubation, which we're usually using about 30 milligrams. But if I just want kind of a quick anxiolysis sedation, I usually use about 10 milligrams. Do you know your dose that you use?
6.
6. Okay, just 6 across the board?
6 for full pacing.
Perfect.
Adult.
Yeah. It's kind of another bunny turtle. It's pretty quick. Comes on in a couple minutes. It's pretty quick off too. If you've ever given it and then tried to intubate someone and not been successful, you see in a couple minutes, 5, 10, 15 minutes, they're usually coming back around. IV is the main route. It can be given other routes, but IV is really the main route we use. Side effect-wise, hypotension a little bit. It should have less cardiovascular effects than a lot of drugs. That's why we use it for intubation, and then respiratory depression as well. And then ketamine. So now we'll talk about some ketamine. Dosage-wise, 1 to 2 mg per kg IV, 4 to 5 mg per kg of IM. Another turtle bunny is not as quick as Versed usually. All these studies show different times, but usually it takes a little bit longer, but it is actually pretty darn quick, especially if you do IV. IM definitely takes a little bit, but IV you usually start seeing effects in the first couple minutes. It's pretty quick off compared to other things. IV, it's usually coming off about 30, 45 minutes. IV or IM may take a couple hours to come off. A nice little thing to know about ketamine, we'll talk about the physiology and mechanism of ketamine. It has this kind of ceiling effect. You get a certain effect, and that's the effect you're getting. You don't go beyond that. So additional dosages, all it really does is prolong the effect. So if I do 1 to 2 mg per kg and I get my effect where they're completely dissociated, I go give another 1 to 2 mg per kg, that's just going to prolong it. It's not going to make them deeper in dissociation because you can't get deeper, but it prolongs it. So it's kind of a nice trick if you just give more knowing, but also knowing in the back of your head, okay, they're going to be sedated for a long time. Route-wise, it can be given really any route. IM, IV are the most common. Intranasal is used for migraines. I've also used it for pediatric sedation. It's pretty quick on with intranasal. So side effects. The main side effects of it are tachycardia and hypertension. That's not too bad. That's why we use it a lot in trauma patients for sedation or intubation. Also hypotensive septic patients because it really actually bolsters your blood pressure a little bit. The tachycardia we do worry about in older adults if they maybe have a history of coronary artery disease. You might not want to stress the heart too much. And then there's the emergence phenomena. So the whole idea of the emergence phenomenon, I'll explain a little bit more in a second, but the patient is coming out of the sedation or the dissociation with ketamine, and their synapses are starting to connect back. And they've connected enough synapses to start getting input, but it's not making sense, and their brain's not totally connected back. So they're perceiving some weird input. They may be still seeing purple unicorns, and then everything's just getting mucked up, so they start freaking out. So that's the emergence phenomena. I hate that it's called an adverse effect, because that is not an adverse effect. I don't care. I can treat that, and I think it's been wrongfully put out there as a dangerous effect in the papers. But really, those are the main effects that you're going to see from ketamine.
We call that the K-zone.
The K-zone, it's the K-hole. Anytime, if he was excited delirium patient or someone freaking out, and I just give him a big thing of ketamine and say, "Sir, you're going to go sit in the K-hole and think about what you said to me." And yeah. K-hole is an interesting place. So, ketamine, let's talk about it. All right. So, ketamine is an interesting drug, and it's always classified as a sedative, but it is not a sedative. It's actually a dissociative. It's a very different type of medication. It works on NMDA receptors in the brain, and what it does, I like to describe it, it takes a pair of scissors, and it cuts off the basal part of the brain from everything else. That's what it does. It doesn't actually depress like all the other meds does. It just takes a pair of scissors and cuts everything else out from the cortex of the brain. So whereas these medications, the benzos and the Haloperidol and Etomidate, slow people down and kind of put them to sleep, ketamine makes people stop. And that's what I love about it. Patients stop. The excited delirium patient, I don't give them Versed, no, they're still a little crazy, more Versed, no, a little crazy, more Versed, oh, now I'm intubating them. I give them the right dose of ketamine and they stop. And that's what I like about safety-wise. It makes it such a more safe environment for my staff and for the patients. In terms of actual safety of medication, it blows every other medication out of the water in terms of safety. We will kill so many more people with fentanyl and morphine and Dilaudid than we'll ever kill with ketamine. It's a very safe medication. What it does, it cuts off the rest of the brain. It brings you down to your caveman brain. So what does your caveman brain do? It makes you breathe and it makes your heart beat. And that's about it. So it brings you down to that caveman brain. And what it doesn't do, it doesn't affect your respiratory centers. okay? And it doesn't affect your cardiovascular centers other than to provide little sympathomimetic effects. So when people say, oh, I gave them ketamine and they stopped breathing, it doesn't affect the respiratory centers. It doesn't, okay? So usually what that is, other drugs on board, other benzos and stuff on board. Sometimes you do see a brief apnea, 15, 20 seconds, and they kick in, they start breathing again. But by the mechanism of the drug, it doesn't affect respiratory centers, and it's extremely, extremely safe drug. This drug got a bad rap for decades, and we're really trying to bring it back because it is a great drug. So to understand how to use it, I think it's important to understand something that's called the ketamine brain continuum. And that was a name that emergency medicine blogger came up with. And I think it's a nice way to describe it. There's different evolutions of dosing in ketamine. I think you really need to understand it to use the drug properly. First off, there's pain dosing. Anyone using pain dosing in the field? 1? Okay, 2, 3, 4, 5, cool. So our dose on pain dosing is 0.1 to 0.3 mg per kg. That's what's called a sub-dissociative dosing of ketamine. Again, ketamine's a dissociative, so sub-dissociative means it shouldn't dissociate the patient. I say shouldn't, because often you give that, especially the higher end, and patients do start saying, ooh, I feel kind of weird. But really, this shouldn't dissociate them, and it's actually a very effective analgesic, especially in patients who are refractory to other narcotics or who have extremity trauma. So that patient, you come in, you give them morphine or fentanyl or Dilaudid, and they're still really having pain. I give a little squirt of ketamine, and often they say, wow, thank you, that really helped. And again, the safety profile is amazing on it. On the other end of the spectrum is the full dissociation. And that's 0.8 to 2 mg per kg. We'll simplify and say 1 to 2 mg per kg and beyond. I say beyond because you can keep giving higher doses and you're going to get the same effect. You don't get increased dissociation. There's plenty of studies where there's a couple studies where 9 times the upper limit was accidentally given and the patients did fine. They just were dissociated for a really long time because, again, the way the medication works. And in the middle is what we call partial dissociation. And that's why I think it's important to understand how this medication works, because I find my residents dosing it inappropriately all the time. The problem with partial dissociation is, like I said, you take a pair of scissors, you cut off all your synapses in your brain. Good, you're dissociated. If we only cut half of those, that's when we start getting these things like emergence phenomenon, people really freaking out. Because again, now they have all their input coming in, but they aren't able to fully express what's going on, and they may have different inputs that are kind of mixing what's going on in their brain, and they start freaking out. I remember one of the first times I ever gave this for a procedure, the girl suddenly went blind, completely blind. But she was awake enough to realize she was blind, and that was just an effect of the medicine. So she's still awake enough to realize that, and she started flipping out, and I started flipping out because I'd never seen that before. So you just see, that's a dangerous zone to be in. I bring up all the time because I'll talk to my residents. They say, okay, I want to go ahead and give ketamine. I say, okay, how much you want to give? I want to give a half dose, 0.5 mg per kg. I say, no. You do not half dose ketamine, because that's when you get the partial dissociation, and that's when things can get scary. Okay, given the safety profile, there's absolutely no reason to not give a full dose of ketamine. Half dosing, you're just asking for trouble. So that's really, I mean, and most pre-hospital folks are going by protocols, and you won't be kind of adjusting your dosing. But just know, I think that's very important to understand how the medication works, because people will half dose it or give the wrong dose. They have a bad event, and the patient freaks out, and they never use ketamine again. Just say, I don't want to use it. I had such a bad experience that one time. So, they're a beautiful thing. If you dose it, because everyone has different dose thresholds, if you dose it and the patient is dissociating but starts kind of freaking out, what do? Give more. If it's in your protocols and you're able to go up to a max, give more, because they're just not fully dissociated. And there are patients we see that don't fully dissociate from ketamine. Just for whatever reason they don't, so you may have to add something else on. Again, the dosage, just to simplify, 1 to 2 mg per kg for our IV dosing, 4 to 5 mg per kg for your IM dosing. It's very important to have the right concentration of ketamine. I rarely use IM ketamine, despite how much I like it, in my emergency department, and the sole reason is I need my 100 mg per ml bottle that's only in my pediatric emergency department. And that's across the hall in different Pyxis. So I can either do my Versed, or I can ask a nurse to go over there real quick, and that takes a while. So most pre-hospital agencies are carrying the highly concentrated one. That's the one we use the least. We usually use the other one for intubation and procedures and stuff. But just know you need to have the right one, because as I've had to do is putting 20 cc's of drugs in someone's thighs. That's a lot of volume, but in a last-ditch effort, we need to do it. So you guys have probably experienced this. You've probably brought a patient in to a hospital you may not go to a lot, or seen a doctor you don't see a lot, and you say, I gave him 500 milligrams of ketamine IM. They say, what? What'd you do? and they start yelling at you. And it's not fair, but the reason they get so uppity and upset is because they now this patient's GCS of 5, and they say, well, shit, now I got to intubate him. Thanks, man. I got to tube this guy's GCS 5. And it's really unfortunate that this happens, because GCS 5 or GCS 3, that's our goal. That's the whole reason I give ketamine. And it blows my mind. We had this amazing week in Jacksonville where I work with our local agency that I don't have any direction with. They brought ketamine on board. I knew about it. Most people in the city didn't know they were bringing ketamine on board. And within 1 week in our department, we had 3 post-seizure agitation patients who were given 400 milligrams ketamine IM and came in as essentially GCS of 3. And completely appropriate dose, following the protocols. Probably wasn't best to give it for post-ictal agitation, but they brought in all 3 patients got intubated. And as the pre-hospital liaison, people are coming to me going, what the hell is JFRD doing? They bring me patients, they overdosed them on ketamine, now I have to intubate them. And then I say, no, they were completely right. They gave the right dose, they met the goal, they dissociated the patient, and that's on you for intubating the patient. There's anywhere that says a GCS of anything is indication for intubation. In trauma, it's associated with poor outcomes to have GCS less than 8, but that's in trauma. And they have ketamine, they're protecting their airway. I don't care where their GCS is, they're protecting their airway. They're now a safe patient. You don't have to intubate them. So that's on us as a provider. So if you ever come in and see this doc yelling at you, there's a nice response. I tell our people, say, thanks for the feedback, please contact my medical director. That's it. That's all that needs to come out of your mouth. Okay? Okay, because you're following your protocols, you're not overdosing the patient. If that physician would actually look at the paperwork and literature associated with ketamine, they know the proper dose is 4 to 5 mg per kg IM. Okay, this is inexperienced physicians who are scared to use ketamine getting on well-meaning pre-hospital providers that are doing the right thing. So again, that's your response. All right, let's move along. So that's the main concern. Oh my God, I have to intubate all these patients now because, damn it, you just sedated them and now I have to intubate them. Well, what's the literature on that? So we're going to look at some papers here from the last couple of years and see what the actual literature is, and we'll be able to tease out why these patients are getting intubated. This is by Shepke, our own Shepke here. He had 52 patients. 3 had respiratory depression. These are patients all given ketamine. 2 were intubated. All 3 of those patients received benzos as well. So in that study, at least, it did show that the ones who also received concomitant benzos had a higher rate of respiratory depression. 2015, 35 patients, 8 intubated total, only 1 was in EMS. And this is when you start seeing a trend of when these patients actually get intubated. If you looked in the papers of reasons for intubation, most of them are just NOS, not otherwise specified, not protecting airway. And it's just kind of these vague, it's never really hypoxia, it's never respiratory arrest, it's just, quote, not protecting airway. And this is the experience I've seen anytime someone came to me and said, man, JFRD gave that guy ketamine, I had to tube him. Okay, why? Oh, well, he wasn't waking up for me. He wasn't protecting his airway. Was he hypoxic? No. Was he breathing? Yeah. Okay. It's not that they're not protecting the airway, it's that the provider isn't comfortable with the situation. Burnett, 49 patients, 14 intubated, 0 in the field, all in the emergency department. 135 patients, 85 intubated, only 4 in the field. And again, there may be real reasons for these people being intubated, but if you really look at in the details of the paper, it's usually just that the provider wasn't comfortable with it. 49 patients, 28 intubated, none in the field, and I love this, 1 single physician in that group was responsible for 10 of the 28 intubations. He was an overnight doc, and they came in, he's like, fuck it, and just tubed every one of them. I thought that was awesome. All right, so it all comes down to understanding the mechanics of ketamine. It does not cause primarily respiratory depression. It can with other medications. It can cause temporary apnea, which resolves. It's a very safe medication. If you don't give enough, you'll pay for it. So please just use it appropriately. Every protocol I look at is in field so far has been very good with the right dosing. But if you have any questions, please contact me. We're going to wrap up with some cases here. So that patient comes in, that psychotic patient. Again, my resident yells out, 5 and 2, 5 and 2. And I say, hold on, let's let's figure out what's going on here. And so this is where you just kind of, some of these patients you can talk to and say, kind of at least 10 seconds gauge the situation. Sometimes they just need their Haldol. That's all they need is say, dude, I just need my Haldol. And so you give that to them. They're calm, they're controllable, they're directable. Sir, do you mind come sitting down on the stretcher here? We'll help you out. And they can actually do well with a little bit of Haldol. If they're floridly psychotic and you think they might be a safety issue, then that's when you need to go ahead and take them down. And these cases right here are my little personal algorithm I go down. So first off, what I usually start with is 5 milligrams of IM Versed. I often do 6 only because in our department they come in 2 milligram vials. Most pre-hospital agencies have the 5 milligram vials. So I'll usually give 5 IM, or if they already have an IV, and I'll give 2 to 4 milligrams of IV. But I think really going a little higher in your IM dose, a lot of my residents try to do 2 milligrams IV of Versed, and that really is a low dose. Then we get them nice and sedated and chilled out. We can put our restraints on them. We can kind of control the situation, which is nice. And then I'll maybe give them their Haldol. So if I know they're a psych patient, a lot of our psych patients, we know them well, we have records on them, then I'll go ahead and give Haldol. This is what I don't like about how my residents do it sometimes. Just upfront, boom, Haldol, boom, Ativan. Or boom, Haldol, boom, Versed. But they may not be a psych patient. And Haldol has good sedative properties, but it's for a specific reason. And now you're kind of muddying the picture. So I like to at least control the situation first and then go from there. I got my excited delirium patient. I'm worried if he's about to eat my face off as well. And we've all seen this situation here. You got your whole staff trying to hold this patient down. What I do with these patients, again, very first off, I try 5 milligrams IM Versed. Often when they're this crazy, that doesn't really do it. But at least it's giving us a little time. It's going to start working in the system. And then we had one just a couple nights ago, and within 5-10 minutes, by the time everything settled, he really did start chilling out. Again, what that lets me do at that point, I can then get my wrist restraints on, I get my IV, I can get them on the monitor, get them on my end tidal, and go from there. Usually at that point, if that's not working, I get my IM ketamine, or my IM Midazolam. My next step is going to be ketamine. And I like to do my Versed first so I can try getting an IV, only because it's harder for me to go get the concentration of ketamine I need for IM. If I had that high concentration on hand, I'd probably use that first. But I usually get my IV established, and then I'll go ahead and give 1 to 2 mg per kg of ketamine IV. So again, here's your dosing for your ketamine. I like to push it over 1 minute. I always tell my nurse, and you may tell your partner, don't waste that ketamine, because ours come in 200 milligram vials, and usually, boom, they give 100 and sometimes toss the bottle. First off, we were in a critical shortage of ketamine, which finally we're off of. I think that was my fault. I apologize to everyone. But that was really tough, because I do like the medicine a lot. But also, even if 30 minutes into it, they're still chilling out and everything, I'll give them that second 100 milligrams, knowing that all it's going to do is prolong their sedation. It's going to give me a little longer window, knowing that they're not going to stop breathing because I'm giving it. So I usually have them not waste that extra medication. I do sometimes use it as a first line. I just have to go get the proper concentration. But I'm seeing a lot more pre-hospital now using it as a first line. I think that's fantastic. It's just going to take a little longer than Versed to kick in. Just know that. And then procedurally, it all depends on what my procedure is and how much length the time I need. Usually in the field, you're going to have pretty quick procedures. Usually if I need less than 2 minutes, that would be like a reduction or a cardioversion or something like that. I just give 2 milligrams IV of Versed and wait a couple minutes, give another 2 milligrams. Pretty safe practice to do. I can also get the Etomidate like we talked about. Palm Beats are doing it for cardioversion or pacing, about 10 milligrams IV. For prolonged sedation, so some of you guys may be working in the field that you have hour-long transport time, then again, it's just going to be our usual dose of ketamine, and redosing that probably every 30 to 45 minutes. Cool. We'll add that link again, references, handout, slides, also all my contact info. Feel free to contact me about anything. If anyone gives you shit about ketamine, send them my way, and thank you guys so much.